am Dr. Anchal Gupta. Oh, this is not the right presentation. Acha, cool, here it is. And I am going to speak about T-cell target therapy in ocular surface conditions. So it's been quite a lot of time that we have been using cyclosporin, but the good thing is that we have other things also to ponder to and compare to. So cyclosporin has established itself from several years for ocular surface dry eye. We all know by now that dry eye is essentially a cascade of inflammation. It is nothing but a cycle of inflammation on the surface of the cornea in the tear film. And it is a closed loop cycle. It is the inflammation that causes dryness and the dryness that cause inflammation. So it's almost like a chicken and egg theory. What came first would always remain in a blur, but the bottom line is that the meat is always there. That is, the inflammation is always there, and a cascade of T cell and the inflammatory inhibitors are there on the ocular surface. And if we really want to treat dry eye, we will have to treat the inflammation. This is very contrary to how we have been treating dry eye for years, where we were treating by providing tears. But we all have to understand that that is not treatment, that is rehabilitation. But treating a dry eye would need killing the inflammation and the inflammatory cycle. So topical cyclosporin has established itself to be a molecule which targets the cytokine release. The demerits that were always there, and anyone who has used cyclosporin in their practice would have realized that its bioavailability is very limited because it is not water soluble. So it is available in forms as unims, and they are still very irritant because burning and the patient compliance is fairly poor. There is also a limitation of possible interaction with certain systemic drugs. It was further researched that instead of focusing on the cytokine release, we should focus directly on the T cell activation, and hence came the role of LFA1 ICAM1 interaction to prevent the perpetuation of inflammatory dry eye disease and develop liftigrast. Liftigrast is not new in the market. The US market had Xiadra for the longest time, but for India, it is a paradigm shift that we have ultimately liftigrast accessible to us, that too in a price point where it is not pinching the pocket. So it is the first and the only drug for the treatment. So it's very important here to focus on the word treatment, because we are not talking about rehabilitation of dry eye. We are talking about treatment of the signs and symptoms of the dry eye disease, and liftigrast is the only one approved by US FDA for the same. So it stops the T cell activation directly. So it's just like cutting the roots bang on where they were arising from. The benefits of liftigrast vis-a-vis cyclosporin is that it has excellent bioavailability, does not have the limitation of burning and stinging as was there in cyclosporin. And while cyclosporin had a time of action of 90 to 180 days, which was the biggest limitation, liftigrast shows its effects in 2 weeks itself. In my practice, I think it's even before. You get the patient on the follow-up of 10th day, and the patient does mention you कि डॉक्टर साहब ये दवा तो काम करती है, इससे हमें आराम मिलता है. So there has been studies that have legitimate proven that liftigrast has reduced the dependence on steroid and artificial tears. So any patient of dry eye, the only thing we were doing earlier was providing lubricants many times in a day and steroid to combat the inflammation, which we knew had its own added side effects. But with the help of liftigrast, the dependence on steroids and lubricants have reduced. Not just that, basis the understanding that liftigrast is actually acting directly on the T cell activation, it is now been perpetuated and also documented that it is helping in inflammatory MGD as well. So that says it's not just aqueous and mucus dry eye, but even if the lipid layer is involved, even if you have a patient of dry eye with MGD, liftigras can be used as a drug of choice, and hence it becomes very significant in patients of moderate to severe dry eye. There was a great noise until last year that do we have a study that documents the role and efficacy of liftigras in Indian population. Thankfully, last year a large study was published in IGO, which had a comparison of liftigrast with CMC. Although there is a point of contention where that why liftigrast is compared with CMC, it is not comparing an apple and with an apple. It is comparing an apple with probably a brinjal. But then the idea of comparing the two of them was because ultimately we also want to convey that liftigras can reduce the amount of tear lubricants we are requiring in day-to-day life. And very clearly, liftigras came out to be a clear-cut winner in terms of the several quantifiable index, mostly the OSDI index and the tear film breakup time. And the study conclusively documented that eventually just liftigras could be used as a twice daily dosage in patients of dry eye. There were barely any adverse events that were noted. And also there's a study where liftigras is compared with cyclosporin that's published in the Cornea Journal. And there in that study, there is an inconclusive favorability to either of them. But yes, definitely there is no adverse event reported. So we can very safely conclude that liftigras could be the paradigm of medicine which we can use in our patients of dry eye, especially with the digitalization of world. We are seeing that dry eye has already become an epidemic. The other interesting thing where liftigras has been established and I am also using remarkably in my practice is for the corneal haze. It is established that corneal haze is also caused by the movement of the T cells and the inflammatory cells, and because liftigras directly helps the circuit from the beginning, it can be used to prevent the corneal haze as well, especially in patients of post-refractive and post-PRK dry eye. So there is a study in the Journal of Ocular Pharmacology where a corneal ulcer was induced, and overnight liftigras usage clearly documented that the corneal haze did not establish. So the benefit of liftigras here is that it is selective and T cell target specific. It has excellent bioavailability and hence could be easily formulated. It has early onset of action, so hence in a generation of people where they want everything delivered in 10 minutes, we can tell our patients that they begin to start feeling better from the 7th to the 10th days. And now in the last couple of years, we have legitimate clinical studies to establish that it has reduced the requirement of steroids and artificial tears, and then yes, it doesn't need refrigeration. In my practice, although the drug was introduced for dry eye, but I really innovated, and one of the few conditions which I found it really useful was post-conjunctival SPKs and PEs. So we had an outburst of conjunctivitis in Delhi last months, and all the patients who had come with several PEs, which we had always seen would lead into permanent scars, they had practically no scarring left. So that's one place where I'm using liftigras Sika drops a lot. The other thing where I am using it off-label is VKC in children, because mostly children with severe VKC, and especially those who get shield ulcer, they end up having corneal haze which is permanent. So although liftigras is not established for use in children, but cyclosporin was established for children less than 17 years. So I'm off the able using it in the patients of VKC. It's too early to present it as a data, but yes, my patients are coming up satisfied. The another thing where I have started to use it, early recovering corneal ulcers. So the moment I see that the cornea has begun to scar, the active infiltration has gone down, I am adding liftigras in my patients and I see it to be giving very good results. I've not backed up with pictures because this is something which I have started in the last 2-3 weeks, and I think at least for condition like corneal ulcers and stuff, it's good to wait for 3 months to clearly see that it has been of help, but it is clearly of help in such conditions. And post PRK, I've made it a mandate that for patients with PRK with power -4, I'm adding, somehow I'm not adding on the day one post-op. I myself don't know what's stopping me, because the post-refractive patients are very, very demanding. So I still have this fear in my mind that they would probably complain of irritation. So I'm adding it from 1 week onwards, and it has all been going fair and fine. So here I would conclude that with Liftigrast available in India and with Indian demographics, we have a brilliant tool in our hands. Thank you so much. I'm open to questions, if any. I'm Dr. Anchal Gupta. I'm very sorry I didn't do that. I'm Dr. Anchal Gupta, and I have my organization by the name Netram Eye Center. It is Eye Center in GK2, and Netram is also a NGO which is working across the country for community work. I specialize as a cornea refractive and cornea and cataract surgeon, and I've graduated from King George, Lucknow, and SRC from Maulana Azad, Delhi. No. So I must appreciate you had come very well in time for your session. Yes. Sir, I would beg to differ here with all due respect. Yes.
pouting out of the lubricant fluid from the glands. You can even feel it, There have been examples where you can feel the edema of the lid when you see that it is due to the inflammation that may be having glands. So what you have to first is number one, never ever say that lubricants are not effective. You have to find out the root cause of the dry eye disease. Find out the reason. And only if you find, because these drugs, cyclosporine and liftigras, they are all also toxic drugs. They are all toxic drugs. You can't use them randomly like that. So for God's sake, it's a, I'm also as a teacher, because I'm still a teacher, being
Yes, sir.
professor emeritus, I'm still a teacher. You see, you must never ever say like that that there is no treatment. I mean, all the diseases are inflammatory. So I give an example of lubricant. So you have to find out and then decide what, and also the type of lubricant is important. Whether you use CNC or methyl solution only, or you have polyvinyl and other things, and we have now this viscoelastic. What is the name of that?
Sodium hyalurate.
Sodium hyalurate. Those drops have also come. So anybody wants to? We were talking about dry eye. So
Sir, I just wanted to, yes. So when I said, I did not mean that all dry eye is inflammatory, but all dry eye ultimately land up in inflammation.
Not necessary. No, again, not necessary. Only if there is very scanty lacrimal fluid, and especially when it is not draining outside. Remember one thing: it is not draining out, because in lot of older people, the NLTs and the canaliculi also, they are shrunk condition. It's very common. So if there is stagnation of the lacrimal fluid, even if it is scanty, then only the inflammatory, then it becomes toxic. So that's what I'm saying. See, it's a vast subject. You have to identify the cause. See, there's another important thing. Last year in Jaipur, we did on the surface ocular disease, which is important, and Dr. Rohit Shetty, who had come, is one of the very detailed, on surface ocular disease. I was also chairing that session in Jaipur. So he said there are two important things again. The amount of lacrimation of the lacrimal fluid which is there, you see, and the symptoms of the patient. Sometimes, the lacrimal fluid is not too deficient, but there are a lot of symptoms, a lot of irritation to the patient, there is burning, they can't go out in the sun, there is a lot of photophobia and all that. So the question was then asked that what type of lubricant you have to use for symptoms. So whether you treat the symptoms first or you treat the root cause of the disease. So that's again debatable. But what the patient wants is that I should be relieved of my problems, of my pain. I can't go out, aadhar कागज दे दीजिए, फिर भी problem होगा. So you have to treat the symptoms of the patient also.
Absolutely, sir. Absolutely.
Anything else you want to say?
Thank you, sir.
You want to say anything else?
No, sir, I'm all good. Thank you so much, sir.
Dr. Elizabeth, she's from Kochi,
Yeah.
one of the leading ophthalmologists of Kerala, and Dr.
Sir, how would you treat your Sjogren syndrome patients for dry eye?
Yes,
Would you not?
now the question
Yes.
arises, Sjogren syndrome. Okay. There is a tremendous amount of tear deficiency there. Almost, you see, because it is simultaneous. उसमें आपके gland भी इफेक्ट हो जाएंगे और root भी इफेक्ट हो जाएगा. So you treat it because it is not inflammatory. There's no inflammation in it. Purely the tears have stopped seeping. So here is the reason where you give strong Suchitao. So you treat with the best of the lubricant you have. Now we have hyaluronic acids and we have other things. You treat that, and you have to treat it because they are dry eyes within a few minutes again because there is no tear. So you have to use it even hourly if you want to treat it, even hourly lubricant, and you have to treat systemic oral steroids.
So would you consider punctal plug in your patient of Sjogren's syndrome?
Yes, yes, yes. That is another. You see, now we have not gone into
Yeah,
interventional intervention,
right.
but
Perfect. Thank you, sir.
but you see, these are the cases where you have to, you have to try everything which is possible in the book.
Yeah.
आप पंक्चर प्लग करिए, आप उसको कॉटराइज करके बंद कर दीजिए पंक्टा को, plugs sometimes they come out and when we just close the puncta by cautery, both upper and lower both, give lubricants, even sometimes tarsography has to be done.
Yes.
तो जमाना था जब tarsography
Yes.
करते थे हम,
बहुत हुआ करती थी
didn't
ये
have
सब.
anything else,
Right.
30 years, 25 years
Yeah.
back. But now we have punctal plugs and we also have now, we can even do cautery.
Yes.
But dry eye disease, what is now known as, what you call it, a dry eye syndrome, whatever you call it, is a really a problem, especially in women, because of the menopause age. बहुत बहुत प्रॉब्लम है. एक बात आपको मैं और बताता हूँ, आपको भी बताता हूँ. Dr. Leela, this is something, it's an eye opener, because it is from Kerala. That's why I'm specifying it. Because I've been practicing for last 40 years. नहीं कोई बात नहीं, इधर आवाज बैठती है. मैं जब 150 की क्लास को पढ़ाता हूँ बिना माइक के, तो फिर ये क्या है? How are you, Suchita? Nice to see you. So what happens? मेरे पास एक पेशेंट आती थी, लेडी थी, कोई around 45-50, menopausal, severe dry, and she had gone to almost half a dozen ophthalmologists. Somebody referred to me because being senior and professor there, they I am the pass लिखे. I tried everything. I tried CMC भी कर लिया, ये भी कर लिया, वो भी कर लिया, पंखा भी ब्लॉक कर लिया, nothing happened. आप बिलीव नहीं करोगे, डॉक्टर लीला एंड this somebody, वो पता नहीं, I don't know what happened, because वो untreatable हो गई थी, patient was untreatable. Somebody brought a drop to me, and that's an Ayurvedic medicine from Kerala. Sunetra.
Sunetra. Yes.
How do you आप तो वहीं की हो, केरला की. और वो पेशेंट ने मेरे को बोला कि सर मैं I don't know how did they get it, I don't know, but दिन में 3 टाइम डालती थी, just 3 times, morning, afternoon, evening, and all the symptoms disappeared. I was shocked, because we don't believe on these things so much. But उसके बाद मैंने at least I have referred, I showed that medicine to at least a dozen these patients for dry eye, and everybody has responded.
There is research going on in using coconut oil
Yeah.
and some ingredients, herbal ingredients for dry eye, where Dr. Rohit Shetty is also interested because he himself,
I know that, that's why I referred.
yeah, he said that a lot of these medications with coconut oil in it, the Ayurvedic medicines, we have to try for dry eye.
Coconut is same like lubricant. Ultimately, it is same like lubricant.
And
क्या डालती है?
in Kerala, we used to have this castor oil used for kajal.
Yeah.
For making kajal in children, we make at home. Yeah.
With the homemade remedies, तो ठीक है. But Sunetra, then I wrote to those fellows in Kerala, they didn't respond.
They use coconut oil, virgin coconut oil.
That is like lubricant also. ठीक है, Anshul,
Thank you,
very
sir.
good.
Thank you, sir.
You incited and excited me